So good morning everyone. My topic is glaucoma associated with vitreoretinal surgeries. I shall begin my session showing you a few cases. This first 53-year-old lady underwent a combined cataract with IOL along with 25 gauge pars plana vitrectomy with endolaser and silicone oil for rhegmatosis RD. And what you see here, looking at the contour of the iris, you can see the iris Bombay, and this patient had also undergone a choroidal drainage along with the procedure, and patient had a little early postoperative fibrin rise in the AC, and you can see in the lower picture that the iridotomy, which is patent, has relieved the iris Bombay. The next patient is a Maldivian who has presented a little later, say 3 months of diminution of vision history is there, with again with a rhegmatogenous RD. See the multiple holes inferiorly along with PVR, and patient also underwent a combined surgery, but here he has also undergone transcleral cryo along with silicone oil, and this is how the anterior chamber looked like on the first postoperative day with the fibrin membrane in front of the IOL. The third patient underwent vitreoretinal surgery for an epiretinal membrane, and the patient underwent again a combined surgery with the small incision vitrectomy, along with the only difference being a gas tamponade was used and SF6 tamponading was done, and the patient was good in the first post-op visit and at the 5-day visit, but except for a little posterior sine K inferiorly, and by 10 days the patient came with an acute IOP rise with a lot of pain, intense pain in the eye, and this is how the cornea looked with diffuse edema and an iris Bombay. I'll be discussing these through the session. So transition from the conventional 20 gauge vitrectomy to the transconjunctival small incision vitrectomies may have improved retinal surgical outcomes, but definitely the post-operative IOP spike, which was a complication even with the traditional, still is common. The reported incidence in literature is 8.4 to 14.8% of secondary glaucomas, and the definition itself is a challenge because one has to differentiate what is the definition of secondary glaucoma. It refers to an immediate or delayed post-operative IOP rise more than 22 millimeters of mercury with or without an associated optic nerve damage or visual field damage. That's important. Second, further important thing is that progressive damage assessment in the post-op visits again is difficult because it's difficult to quantify the glaucomatous damage, which is very important in the management strategy. So in the post-operative period, IOP assessment is of paramount importance. Now, which tonometer would you use? So this study actually compares NCT, and in the pilot study it compared the Corvus with the GAD, and their further study compared NCT with Ovare with GAD, and it's all come up with the conclusion that NCT underestimates in silicone oil tamponade eyes, also in gas-filled eyes because of the gas compressibility. So Goldman is the gold standard. So in silicone oil tamponade eyes, the biomechanics is definitely altered, the corneal hysteresis is lowered, and the corneal resistance factor increases. So GAT is the gold standard, and literature says even tonopen has good agreement in such eyes. But it depends on what one is used to in practice. So how do you approach such cases? You have to assess whether it is an acute onset or a delayed onset IOP spike, whether it is an open angle or a closed angle. What was the vitreoretinal procedure that has taken place, whether it's buccal, whether it's vitrectomy? If so, with vitrectomy, what was the tamponading agent, whether it's oil or it's an intravitreal gas, whether there were any history of intravitreal injections, like especially steroids earlier, and any recent anti-VEGF injections, and the role of endolaser and PRP. So you have to assess the cause, the pathogenesis, which is the most important in planning outlining the strategy, and the severity of damage, whether it's only IOP rise or whether it's this damage. Dependent on that, you have to have a tailored approach to get the optimal visual outcome. So this table actually shows on the right-hand side various the incidence of glaucoma with the consequent based on the type of surgery, and you can see that the highest is for the intravitreal triamcinolone, where the onset has been at 2 months, and post-vitrectomy you can either have an acute rise in 48 hours period or a late rise. In oil-filled eyes also you can have both early and late eyes. Buccal produces by 3 weeks to 1 month, a 30% incidence is noted. The early onset, the causes could be a pupil block, could be an inflammation, and even sometimes choroidal hemorrhage can account for a acute IOP rise. And late onset is the steroid-induced or the trabecular damage because of the multiple surgeries or buccal effect and a chronic inflammation. Open angle, again, could be because of steroid-induced or trabecular block, post-vitrectomy by the blood cells and inflammatory materials, and the closed because of forward iris push of the iris lens diaphragm and peripheral anterior sine K or a pupillary block. So coming to buccal, who in buccal, alters the total geometry of the eye, and so obviously the angle is distorted. And who are at risk? Those who have a pre-existing narrow angles, which is very important to know, and those who are older and who have an anterior buccal, because vortex vein compression with choroidal congestion and the rotation of the anterior rotation of the ciliary body with the forward shift of iris lens diaphragm accounts for the angle closure component, where the angle closure glaucoma is reported as 1.4 to 4.4%. So you can have an acute IOP rise with a pupil block even in buccal cases, and you have to document the disc findings in the post-op visits, because we can show cases which have normal angles and normal IOP, but progressively and sequentially when you follow up the patients, they can have damaged discs with fields, which is difficult to identify. So we can see such cases in glaucoma with buccal. So you have to document the disc picture in your notes in the post-op visits. In buccal, medical management is usually successful. Cycloplegics to push the iris lens diaphragm posteriorly with the topical steroids aggressively, and you can use acrosuppressants, but miotics to be avoided. In buccal cases, again, laser not much of a role, and conjunctive trabeculectomy depends upon how much of conjunctival scarring is there, and cyclodestructives are always unpredictable, so GDD is definitely a good relief. In this context, I remember one patient of mine who is just 26-year-old, who is a young patient, myope, who actually presented on first examination, found to have a lot of flatness in both eyes, the right eye showing some sequelae of probably a regressed ROP, and so buccal was planned, and this patient was sent to the glaucoma consultant for a baseline evaluation to assess the angles, which is very, very important step. After surgery, like you can see in the lower picture, good buccal effect was noted, but we had a tough time because when you have lid edema and congestion, it's very difficult to record IOP in such eyes, and to follow up the patient when you get IOP spike at 3 weeks, whether it's because of steroid or whether it's because of a raised episcleral venous pressure, to really say that the patient has high IOP, because cornea need not be as edematous, and so it's difficult to monitor IOP in such cases. But a warning is that don't jump and do a filtration surgery. You can wait, and this patient took low steroids were given for about almost 5 to 6 months, and she's doing well. So after vitrectomy, the incidence, it is nice to note that phakics have a protective effect because the lens acts as a scavenger, so the free radical damage to the trabecular meshwork is to a great extent less, so phakics do better, and this is a reported incidence of 5 to 22 millimeters in 60% of eyes. They can have an acute rise or a chronic rise, which I already showed you, acute in 6 to 48 hours period, and chronic even after 2 months, and can go up to 5 years. You can have an open angle mechanism, and in chronic cases, you can have a rubiosis and NVG component as well. And if a buccal is combined with, or if you have, depending on the tamponading agents, further IOP rise. Intravitreal gas induced, it's very important to note here is that you should always dilute, because undiluted concentrations of gas, whether it's the sulfa hex, SF6 or C3F8, both of which are FDA approved to use, SF6 can expand 2 times and C3F8 can expand 4 times. So the non-expansile concentrations have to be ensured, and maximum expansion is first 6 hours. And you can have a pupil block. The mechanism is with expansion, you have obviously a forward push of the iris lens diaphragm, and you can have a pupillary block. So you should not have high IOP, because obviously the risk of CRAO will be high if you have a high IOP. And if you have used a most important thing is that a lot of precautions, like you should warn the patient not about air travel, because when you ascend or mountain climbing, etc., the gas expansion risk is there. So you should know how long the gas lasts, should restrict such travel. Even scuba diving, and the patient comes up, it can, at atmospheric level, you can have expansion coming up. So that's the important of gas tamponading. But if you use a non-expansile thing, you can medically manage most of the time. In rare cases, only you need a sequential gas removal. Silicone oil filled eyes is very commonly met with. The incidence reported is 11 to 48%. Aphakics are at risk, and this patient, it is very difficult to assess when the total AC is filled with oil, actually, because it is the oil being transparent. And here you can see that you can see a kind of, when it is in the AC, you have to look for the sheen and look at the margin to really identify whether it's a pupillary block because of the silicone oil. So you can have an open angle mechanism because of trabeculitis, you can have angle closure mechanism because of synechial closure, or sometimes you can have an AC overfill where you may have to do partial removal. Combined mechanisms when the PI is close. So early presentation or late presentation has been already told to you. The patient showed down, actually, SOR was done. It was a young patient post-trauma, so oil removal, there's a little bit of oil left here, and such oils, whether need to be removed or not, is really, only emulsified oils actually have a detrimental effect. I think such small oils left behind in AC probably need not be aggressively removed with an AC wash. And emulsified oils causing hypopyon, if late, you can have ocular surface issues, and this is known to all that this will need surgery. So what are the surgeries possible? Either you can remove the oil alone, but combining with the glaucoma filtration surgery, always guarded because of risk of hypotony is there. So prefer that the VR surgeon tackles the SOR and then go for the glaucoma filtration surgery, because if the surgeon is planning a tube in the pars plana route, then there cannot be a risk of the oil blocking the tube. So these are the various options. Either you go for oil removal followed by the glaucoma filtration surgery, which could be TRAB or GTD, depending on the. So this is a patient where I would like to show how inferior iridectomy helps. That's called the Andos procedure, and it's a patient who underwent vitrectomy with buccal and is having not much of a damage to the discs. Post-injections against steroids, triamcinolone or Ozudex, they can produce a lot of rise, and the mechanism could be because of the injection-induced increased volume, and chronic IOP rise because of the trabecular meshwork damage. So these are the anti-VEGFs which are given, which can have direct toxicity or which can actually damage the trabecular meshwork. PRP or endolaser, again, the amount of laser energy used and the multiple procedures linked with can explain the IOP rise. You can have swelling of the ciliary body and forward shift, but if you avoid multiple procedures and you treat with anti-glaucoma drugs and steroids and cycloplegics, it works. So this is a summary of all the causes on the left-hand side with acute or IOP rises, which I have already explained in the discussions. Management, most of the time medical management suffices with intense steroids, cycloplegics, and anti-glaucoma medications. Like in this first patient, aggressive steroids brought it down in a week's time, after which the anti-glaucoma could be stopped. And lasers are very helpful, and what should be understood is that, like in the first case, the patient underwent several laser sittings at 10 days, 2 months, and 6 months post oil removal. So if you can keep do the sequential laser PIs, because they get blocked with fibrin, and maintain do not allow synechiae to set in, you can prevent damage. This is the third patient with the gas tamponade who had a patent iridotomy and an open angle always. So the patient also is doing good. But when pallor sets in, again, assessment becomes difficult to know whether it's progressing or not. So indications for TRAB is only when IOP is uncontrolled with maximal medications. But to do a TRAB, you should have good amount of superior conjunctiva available. That's the challenge. And GTDs, again, when the buccal is there, obviously the space is less for the GTD. But I think GTDs, a lot of modifications are there, but they do well if you can put the tube over the implant after dissecting the conjunctiva over the implant. Inferior quadrant GTDs have been proposed as modifications. Pediatric valves have been proposed, and the tube insertion in the pars plana has been proposed as modifications, but post-op hypotony in vitrectomy eyes is always a complication. This is the last patient who is a one-eyed, and it's always difficult to say this patient is underwent vitrectomy elsewhere. You can see the inverse IOP and an advanced glaucoma and a shallow RD when the patient comes to us. And what do? Do you go for a limited TSCPC, or do you do a surgery, or do you do a SOR with AC wash? It's always a dilemma to the doctor. Now, amongst the MIGS, GAT is promising because it can bypass scarred conjunctiva, which is commonly seen in post-FAR surgery. So to conclude, glaucoma or secondary ocular hypertension is a common complication post-vitreoretinal procedures. Preoperative gonioscopy important. Identify those at risk for closure important. IOP elevation to be monitored and managed. Mechanism to be understood whether open angle or closed angles. Most of secondary glaucomas can be managed medically, and small proportion may require a laser or surgery. So recognize early and timely manage the IOP for a good visual outcome of the patient. Thank you.
Thank you, ma'am. That was very informative.